Just say good things.
Yeah.
It does do good things. It does do good things. It does really good things. It was actually developed for opioids. Sure.
Fibrinolysis.
But Dr. Justin says it helps the environment keep clots that it's formed.
That is correct. That is
Can you repeat that,
correct.
TJ?
It produces a climate for the clots that have already formed to keep forming.
Okay. So when we have clots form in our body, not long after those clots are formed, your body starts to try to return to homeostasis. And how it does that is through, so if you have a clotting cascade that uses fibrin, it does it through fibrinolysis. It tries to break down those clots. Specifically, it sends out, you guys will recognize this, tissue plasminogen activator, TPA. That breaks down clots. This is naturally occurring inside of your body, okay? What TXA does in reality is it blocks this TPA's mechanism of action. It doesn't allow it to do its job on the clot. So, does TXA form clots?
No.
It does not. It doesn't form clots. What it does is it prevents clot breakdown. Okay? Why this becomes really important is A, we want to keep the little clots that we have, right? Like, keeping clots is a good thing. But B, also, our body if half of our system is trying to break clots down, the other half is trying to keep up with it and releasing more clotting factors. Well, what happens if we run out of clotting factors?
TXA.
And this kills a lot of trauma patients.
So does this help the thrombin and prothrombin?
Intravascular coagulopathy, right?
Yes.
Keep them,
Because your body doesn't,
prothrombin
Yep.
acting, keeps them activated.
yep, your body doesn't need to release as much because it's not breaking it down as well. It's creating an environment that makes the clot stay for longer, okay? Now, TXA has a lot of debates on its dosing, right? Your guys' protocol will probably have like a gram of TXA in an IV, 100 or 250 drained over 10 minutes.
Yes, that's a nice thing.
Yep, yeah, it's very nice. TXC recommends 2 grams of TXA pushed.
Oh, good. That's good.
There you go. What they're finding is we're probably underdosing TXA in major traumas. And we need to get it in there, and we need to get it in there fast before the TPA gets released. We want it bound to the lysine receptor as fast as we can. Right? That's what TXC is saying. Your protocols say
1 gram.
1 gram.
Slow and slow.
Over 10 minutes. It's not too slow. It's like you put it in, and a lot of times how this works is like you toss it into the bag and you just leave it, let it drain through gravity, and do something else,
That's a
and then
way.
come back to it. Okay? Yeah, charted as such.
Yes, thank you. Thank you for going there.
So anyway, that's what TXA does. How beneficial is it? Depends on how fast it goes in. It absolutely should not be given after, I think it's like 3 hours, and at 1 hour is even when its benefit is starting to wane. Okay, so the faster you get it in, the better. Sound good? At MedX, ours is 1 gram in the same 1 gram, 250 over 10 minutes, and then we give the next one over 8 hours. And the idea is to counteract that TPA coming in. Okay? TXA's, it's not a wonder drug, but it does help. Okay? This isn't going to save thousands and thousands of lives, and if you don't push it, the outcomes are pretty close, but there is like 1 to 2% mortality benefit, which is big in that statistical type analysis. Okay, so it's a good thing to give. It's going to help. It's really good in OBs. Really good. They actually did a study in third world countries and found that the biggest benefit they could do for postpartum hemorrhage was TXA.
Really, even more than PIT, huh?
Mhm. So think about it in your, they also did a study, so why a lot of people don't wanna push TXA is because they think they're going to form clots, right? And clots are gonna land everywhere. And that has not proven itself, because remember, it doesn't form clots, it just prevents your body from breaking clots down, okay? So in those types of, traumas, GIs, TXA is a really good drug, right? Don't hesitate. If you push it and it was unwarranted,
Whatever.
it's okay. It's okay. Better that.
I think the only contraindication that we have on our protocols is just ICP.
Yes, and we'll talk about that.
That's not really proven.
We'll talk about the crash free study. It's obligatory in any trauma talk. So, I want to talk about trauma arrest. Before we go on, we'll get it out of the way. So, trauma arrests are kind of interesting because the survival rates of trauma arrests are wildly variable throughout the country, okay? And the reason is it comes down to how much you do for trauma arrests and what the trauma arrest mechanism was. Trauma arrests are much more nuanced than medical arrests. We don't just walk up, start ACLS, and then we get what we get. This is a lot different. We have to figure out what happened. So the cause is really important, right? And what are some of the what is probably the biggest cause of trauma arrest that we can reverse right now? Pneumo. Tension pneumo. Boom. Okay, boom. Reverse it. We can fix that one pretty quickly. Needle decompression, get that air evacuated out. If you stab somebody who is dead and you try to relieve a tension pneumo and you don't, okay, I'm sorry, I tried. Generally speaking, if there's a trauma arrest that you think has a chance because of a potential like blunt force trauma to the chest or a stab to the chest, gunshot, something like that, probably bilateral pneumos. After you needle decompress too, remember, we want to put some PEEP on this patient, okay? Probably about 5. Their body has lost the ability to physiologically achieve PEEP. What did we just create when we do a needle decompression?
Sucking chest wound.
We just created a sucking
hole in
chest
their
wound.
chest.
Oops. And that's fine. It's better than having pressure in the chest, right? People survive sucking chest wounds much better than they survive tension pneumos, right? So remember though, we want to add some PEEP to this system, probably about 5, to try to oxygenate these people because we took that ability away with that needle to cause its own PEEP, okay? So yeah, tension pneumos, number 1. A couple more things to think about that you can fix. Anything that involves a tourniquet.
Any hemorrhaging?
You can get a tourniquet on there, boom. So like a limb, usually. A limb lac, something like that. You can do a lot of good even if they have bled out. It's really hard to get patients who've gone hypotensive and traumas and get them back. But if you can get a tourniquet on there, plug the hole, then fill up the tank and start your resuscitation, you might have a chance, okay? The problem with trauma arrests is that if you haven't plugged the hole, every time you do a compression, where does the blood go? Right out that hole. Suboptimal. What happens if we push epinephrine?
That's even better.
Well, now we've pressed it and pushed all of that blood out of the hole. Epinephrine probably does not have a good place in trauma arrests. Now, in your protocols right now, it says push epinephrine. That's okay. It's probably not gonna help. Might hurt a little bit, but it is your protocol and these are going to be legal cases in some ways, right? Biggest thing though is we wanna be able to relieve the tension. We wanna be able to put on a tourniquet. We want an airway. I'm just gonna put airway. You need to get an eye gel. Eye gel's fine. I'm a eye gel fanatic. I also like ET tubes. They're both good. And the last one that can really, really save a patient's life, absolutely 100%, is a pelvic binder. We'll go over like some of these today. What did I leave off of here that's a normal trauma tool?
C-collar.
Suction.
Oh, traction splint.
Traction splint. We probably don't lose as much blood into that cavity as we used to think. They used to just push blood on these patients all the time, and now they are not as much anymore. I think ultrasound has relieved a little bit of that myth that you can lose, like, what was it, like 1,500 cc's of blood? I think they're more down to like 700, and it's a lot of blood, but it's not enough blood to kill you isolated.
And the pelvis is 2,000 to 3,000, so that's why.
Pelvis kills people all the time, okay? So these are some of the things that like you should concentrate on these traumatic arrests before things like CPR, right? Before things like epinephrine. Think about bilateral needle decompressions, okay? Think about trying to get an airway. Think about stuff like that. Remember, if you are, you guys had the bullet hole with gray matter, like you're not probably going to get those patients back, right? That is what it is. A massive head injury that has caused you to die is probably going to stay that way. The other one is just a hole in the center of the chest in one of the major vessels or the heart. I'm sorry. I'll show you a kick-ass video after this of something they do in like different helicopter agencies around the world to reverse some of these things. But even then, it's pretty hard.
And you want us always to warm our patients and watch the temperature?
If you can, and this is another thing too, right? Like if you have a high index of suspicion that you're gonna do what you can for this patient and see how it goes, maybe you do that on the side of the road, right? Like maybe that's somewhere else. It just depends. That's gonna be very situational. If you can warm them, you'll probably have a little bit of benefit, but it's the same as like a medical code, right? Like if we could warm all of those patients, there'd probably be a benefit, but do we have to like throw heated blankets on Mima, who's got a DNR and such?
No, we just have to make sure we don't get into that triangle
Yep.
spiral.
And, just really consider like reversible causes. This is the big thing, like hunt down reversible causes, and sometimes there aren't any. And they die. Trauma people die a lot.
And, looking at it too, like, there are some things you don't want to survive, because you're not coming back that well, and so that's.
Couple of other things. So there was a Heavy Lies, the Helmet 69, with Dr. Humphreys, and she was talking about make sure this is a trauma arrest. Not everybody who dies in a vehicle is a traumatic arrest, right? Like if they rear end someone going 25 miles per hour, that might have been a medical before a trauma, right? And if it's a medical, work it like a medical, ACLS, all that stuff, right? Here's a little bit of a potential. You see one of those, think medical. VFib VTAC generally doesn't come out in major trauma arrests. What does?
A pre-trauma.
Close. Number one,
PEA.
PEA. PEA is a lot of traumas will come out as a PEA. But if you get a VFib VTAC, there's one trauma cause of VFib VTAC.
Emotional cordis?
What's that?
Is that like emotional cordis?
Yeah, you're close. You're close. On the right track.
Tamponade.
It's not tamponade. It's everybody's favorite.
Torsade.
RONT.
Oh.
RONT is the only time you get, generally speaking, the only time you'll get a trauma that causes VFib VTAC. And that, I have had one of those. Like an 8-year-old kid that got, he was playing baseball, and instead of turning when the pitch hit him, he turned this way and it boop, and right in the chest and died. And then we shocked him and he came back. He stopped being dead.
Is that 1 in a million where the strike hit during like the right time of
Yep,
the heartbeat?
that's it.
Ah,
That's it.
yeah.
Yep. Heart's trying to recover, and you say, "I want another beat," and it can't, and so it goes into V-fit.
Yeah.
Yep. But that would be the only one. And if you get TAC, really think about a medical cause. This might be a medical cause that's happening. She had a case study where the guy like rear-ended somebody else, not going super fast, and she was like, there wasn't a mark on this guy.
Oh, the airbag hit him and caused it?
No, he died before.
Oh,
So he died as he was coming in to and, he passes out and bam, slams into the back. So just think about like medical causes. If we get into a medical cause, work it like a medical code, okay? Like, do we need bilateral needle decompressions? Probably not on a code like that.
It's like super bad asthma, maybe.
Yeah.
That's where your situation.
Sorry.
no worries.
Yep. Hypoxia, we talked about that. Last one is like tamponade, and it's gonna be a long time before they give us the big needles again. Paramedics used to be able to do pericardial centesis as like a last ditch effort, and it was kind of in this. It was in like, okay, you have a trauma arrest, so we're gonna, bilateral needle decompressions, put a pelvic, this was before pelvic binder, put a pelvic binder, put an airway, and then we're gonna
Drop a
pericardial
needle.
centesis and see if we get anything. Yeah, well, guess what? We poked holes in a lot of hearts. So the newest thing now is an ultrasound guided pericardial centesis,
Okay.
where you're coming in and you have one person looking and you can see the tip of the needle move across. Usually you use this window over here. Boop.
So you just follow the 5th intercostal?
I think so. I have not been trained on it,
Okay.
not yet. It may be coming, but and that'll relieve that pericardial tamponade. On ultrasound, that's actually not that hard of a thing to find with an ultrasound probe is a tamponade.
Okay.
So you look at, it's basically you're looking at like up towards the heart this way, and you're looking at like the right and left ventricle at the bottom because we're looking towards the shoulder, and you can see like that sac is like you're not getting any expansion of the ventricles, and you can see that sac just like building and building with fluid, and fluid comes out as like black on ultrasound. So it comes like this black mass is growing and growing.
Oh, okay.
Or sorry, so yeah.
Yeah. The only other way of identifying I've heard is the heart rhythm on a EKG that's like, yeah.
Electrical Ultrarands.
Yeah.
And I mean, if you got Ultrarands and you got a needle, and sweet, good for you.
And they're
But,
still alive at that time.
woo!
Yeah, that's,
But so there's a really good episode on this on the International Book of Critical Care Medicine, and not every tamponade is the same. So some of them are slow, and some of them are like the ones we're thinking about, like boom, chest trauma, blood pressure sucks, they're tachycardic, muffled heart tones, which good luck getting that one. But that ultrasound, that sort of stuff, and they need to be relieved like right now. There's other patients that get tamponade for other reasons, and they will slowly build that over time. And they'll like go in, we drained like 10 off, cardiothoracic surgeon goes out, drains a little bit more, like, so there's different levels to these.
Crazy.
Yeah.
So probably no pericardial centesis,
Probably not.
which I'm not,
Figuring
honestly,
like
I'm not opposed to.
Yeah.
On this topic, I have 2 questions for you. Junctional tourniquets, what are your thoughts? Are they worth the money or are they not worth the money?
I haven't seen any studies that have said that they save a lot of lives. They've been trialed at a bunch of different places.
Super not user friendly, the couple I've seen.
Yeah, they're pretty hard. So if you guys don't know, like junctional tourniquets are things like right here, you can get a tourniquet on, femorals, stuff like that, and maybe, I don't know. From what I've seen, it just hasn't been like sussed out that there's a lifesaver that like a pelvic binder is or a tourniquet is.
And I'll save my second question for later on in your lecture.
Oh, it's okay. You can do it now.
Well, I was, thinking of the guidelines along the lines of permissive hypotension, pressors versus fluids.
On hypotension,
Like, are they? Is the catecholamine depletion versus fluid depletion, right? I guess is kind of. And I know when we were in medic school, it was a shifting precedence, and we went from less fluid, more pressor. And where you guys are at with this?
I would say you have to weigh the two, because pressors generally work less if you don't have a tank of fluid to push around, right? If you don't have a tank of fluid to press. I would say, from what I've been listening to, most people are still saying some fluids, and then switching to the lowest dose pressor that you can. And remember, we're trying to maintain on everything but head traumas, and we'll go over that. American Stroke Association just released new guidelines. But in all of the other traumas, we're trying to keep that system in low pressure. And the idea is that we have clots that form, even the little micro clots, and we don't want to break those off by adding too much pressure. And pressors are really good at breaking those clots off, because now it's not just a slow moving amount of water moving around in blood, it is the heart trying to beat systolically against those clots. So I would say it's got to be in a balance, got to make sure.
Are we talking strictly like blood loss, or can we actually go like dehydration and like sepsis too?
Probably blood loss, because in sepsis and dehydration, you still have intact vessels. So we're not trying to preserve clots in those situations. You are probably not going to see permissive hypotension in those. We just wanted those patients to be normotensive.
Yeah, let's do that.
Okay.